Hey, everyone out there. Welcome back to Rebel. We have got a great article to dive into. I'm here with my good friend, colleague, and podcast partner, Salim Rizai. Salim, good to be back and discussing this.
Yeah, man. Was really looking forward to doing this as a primary podcast, but you were so hot about it, like you just wanted to get this out. So we went ahead and posted the post.
Yep.
Don't ever upset your work partner. So, and that's what you are. You're my work partner, so I didn't want to upset you.
I was fired up. You're absolutely right. So what we're talking about, just to let the listeners in on it, is ANNEXA-1, published in New England Journal of Medicine just a couple of weeks ago, and Andexanet for factor Xa inhibitor associated acute intracerebral hemorrhage. The post went up on the 23rd of May. People can go back there and check out all of the details. But Salim, let me just get everyone into the mindset with a little bit of some background. Andexanet Alfa was really approved in May 2018 by the FDA. It has rapidly gone from approval to widespread use. Andexanet Alfa's goal is reversal of the direct oral anticoagulants. This is your apixaban, your edoxaban, your rivaroxaban. And there's not really robust evidence for the use of this medication. But in the 2022 AHA-ASA guidelines, they gave a level 2A recommendation. They recommended it over 4-factor PCC for reversal. So this is the patient who comes in with an intracerebral hemorrhage. They're on one of these DOACs. What should we be giving for reversal? Clearly, we are leaning towards giving Andexanet Alfa. Many of our protocols support use, but we really don't have data supporting use. And Salim, you and I have gone through all of this data. Almost every article on Andexanet Alfa, we have done a review. Every single time we end with the same thing. What we would like to see is a randomized control trial comparing Andexanet Alfa to 4-factor PCC, or at least to standard practice. And we would like to see an important patient-centered outcome that improves. Now, enter ANNEXA-1, except maybe we don't have everything we asked for. So, Salim, just give a little bit of a quick, what was the clinical question they were asking, and what was the outcome they were looking at?
Yeah, so the clinical question was, does the use of Andexanet Alfa in patients on DOACs with intracerebral hemorrhage improve hemostatic efficacy? And therein lies the problem. The question is that they keep talking about hemostatic efficacy when really what we care about are neurologic dysfunction or function and survival, which has never been the primary outcome in many of these studies. As far as the outcome, it was a super sloppy primary outcome. They called it hemostatic efficacy assessed at 12 hours after randomization. But to achieve hemostatic efficacy, you had to achieve these 5 things. Either good or excellent hemostatic efficacy, which they defined as a change in hematoma volume of less than 20% or less than 35%. An increase in your NIHSS score of less than 7 points at 12 hours. No receipt of rescue therapies within 3 to 12 hours from randomization, and no surgery to decompress the hematoma within 3 to 12 hours from randomization. Now, Swami, what I'll say is that despite this sloppy definition, the definition was primarily defined as change in hematoma volume.
Mm-hmm.
I mean, when we really look at it, that's ultimately what it was looking at. That was the main driving factor of this outcome.
Yeah, and they keep quoting over and over again. You see this in Andexanet paper after paper after paper. What they keep saying is that change in hematoma volume is associated with patient outcomes. So they're trying to tie that surrogate marker to a patient-centered outcome. The funny thing, Salim, is I feel like we've reviewed a number of these articles. They keep saying that hemostatic efficacy is important, but I don't see it coming out in the literature that we have. And it has been a long time since I looked at the paper, but I remember when we had activated factor 7A, and what the idea was is, again, if the patient had intracerebral hemorrhage, if they were on some kind of anticoagulation, at that time it was mostly Coumadin, let's give them activated factor 7A to reduce hematoma expansion. And it did reduce hematoma expansion, but it also increased mortality. And so we stopped using it because of that. So yes, hematoma volume would theoretically be associated with better outcomes. I don't really see it panning out in the literature.
I don't either with any of the reversal agents. I mean, that's the main thing, right? And the other thing which we haven't even talked about is this trial was funded by the maker of this medication. So of course, like, don't get me started. It doesn't refute outcomes, but like, they're going to, mold things a little bit to look at a more positive light of the medication. And I think that's kind of what they're doing here. And they're basically staying away from what we care about and what patients care about, which are things like their safety endpoints, right? Ischemic strokes, MIs, VTE, death, like the things that patients actually care about. I mean, Swami, if you came in with a head bleed and I was able to get your hematoma volume to decrease by 20%, do you care about that, or do you care about the fact that you're going to be able to walk and be able to do activities of daily living and function as a normal human being, right?
Yeah, I can imagine that conversation with the family. Well, I gave this medication and the hematoma only expanded by 5%. However, your family member is dead. Sorry.
Yeah.
It's not what anybody cares about. Nobody cares what the expansion of the hematoma volume is unless it clearly has an association with better outcomes, in which case, just show me the better outcomes.
And then the other thing that, before we get into the outcomes that we're going to talk about is like the dosing of this medication is also super not easy. Some people might say it's easy, but there's like a table of a table that you have to look at, and you have to look at the dose of whatever the DOAC was that the person got. And then was it within 8 hours? Was it after 8 hours? Is it unknown? And then you got to decide if you're going to go on the low dose infusion or the high dose infusion. I'm not going to get into all the specifics, but it's not super straightforward where like something like 4-factor PCC now, we have like just a fixed dose that we give people, and it makes it so much easier in terms of how to give the medication. The other thing is that, and I don't want to get lost in the weeds, but they just keep whittling this population down, right? They keep excluding people. They keep including very specific people. And so then it gets really hard to remember, what was the patient population this applied to again?
Right.
They just keep whittling this down. It's not just kind of all comers. Anyways,
that makes that generalizability very challenging. You mentioned that this was a pharmaceutical sponsored study. We have ample data showing that those studies tend to be biased in favor of the drug, obviously because they only care about the bottom line of selling the drug. They actually don't care about patients directly. They really care about, how do I get this drug sold? So there's lots of biases that are kind of built into this type of a study design. And when we look at the results, Salim, even with all of that bias, we don't really see what we would imagine would come out of this. The other thing to mention is that they changed those outcomes multiple times during the study. And, you and I are not methodology experts. Yes, we do this quite a bit, but this is not our expertise. But even you and I know you can't change these things as you go. Once you start, that's what you're set upon. You can't look at some data and then be like, this doesn't really look that good for us. Let's change it. But that's exactly what they did. Let's get right into those results, because the headline is that this was a positive outcome. It showed a decrease. It showed an improvement in hemostatic efficacy with Andexanet Alfa versus usual care. And the usual care arm didn't really specify what you had to give. Although most patients got 4-factor PCC for reversal, 15% of them did not. So when we compared Andexanet Alfa versus usual care, there did seem to be improved hemostatic efficacy. But Salim, you said already, we don't really care about hemostatic efficacy. What we care about is outcomes. So did the patients do better? Were there less deaths? Were there better functional outcomes? Were there less strokes? Any of those things?
Yeah, so use of Andexanet Alfa doubled. Doubled. It went from 5.6% to 10.3% of thrombotic events. And that was primarily driven by more ischemic strokes and more MIs. And so what you're telling me, Swami, is we have a medication that decreases how much your hematoma is going to expand. And we didn't say this, but to drive their point home, they even looked at that anti-factor 10A% change and said even that was better with Andexanet Alfa compared to usual care. But then they glean over the fact that we're doubling the amount of strokes and doubling the amount of heart attacks when we use this medication compared to usual care. So the answer to your question is no. The things that people care about, patients care about, the answer is no. It actually made it worse. It caused harm.
Yeah, I think that's really important. And even when we look at the NIHSS stroke scale change, there wasn't really any difference between these two. And while death wasn't statistically significantly different, the point estimate favors the usual care arm. And so remember, in that usual care arm, there was 15% of patients who didn't get anything for reversal. So this was really biased to favor Andexanet alpha. It clearly works in terms of changing that anti-factor 10A, but it didn't work for improving patient outcomes. So while the authors state that this is a positive study, I don't think it's a positive study at all. I think what this study tells me is that Andexanet alpha is dangerous for patients. There's no significant clinical benefit to the drug, and there are significant clinical harms. Honestly, when I look at this, I say we shouldn't be giving this to anybody outside of a study protocol until you give me a study saying that it actually works.
100% agree. I mean, that's basically, so what? We reduced your hematoma expansion by 20%, 30%, whatever, but you're going to have all these neurologic deficits, or even worse, you're not going to be alive.
Right.
So I agree. I think the things that people care about, we're showing doubling in harms when we use this medication, and it shouldn't be something that we're routinely using. And then I want to take this one step further, Swami, because you said 85% of people got 4-factor PCC in the usual care arm. How come we don't have any of the results from the 15% that got nothing?
Yep. I'd like to see that too. I know subgroup analyses don't prove things, but it would be really interesting. Did the 15% who got nothing do better? Did they do better than the Andexanet alpha arm? Did they do better than the PCC arm? That's really important to find out.
And although that's not the way the trial was set up, that is basically a built-in placebo arm.
Yep. Absolutely.
That's essentially what that is. And we have none of that. It's not anywhere in the supplements. It's not in the main article. You just can't find it.
Does that make you a little suspicious, right? It makes you a little, and I don't want my suspicions to be the equivalent of knowing, but it makes me suspicious that data wasn't shared, because if the placebo group did much worse, I think that would have been shared. It would have been shared to say, we got to do something. If the placebo group did better, I can see withholding that data, not putting it in the publication, because it kind of says, don't do anything. Don't do PCC. Don't do Andexanet alpha, because there's no benefit to either of those. And when we look at the outcome for the usual care arm, again, if that subset of patients who got nothing did better than PCC, then it makes PCC look worse. It's pushing down the rate of the hematoma expansion and all those kind of things. And so actually the usual care arm might look worse than it actually is, because some patients didn't get anything. If the 15% of patients who didn't get anything did better, then that's also really important for us to know. It's such a mess. And you have the data. We know you have the data, and you're hiding it from us.
And then I'm going to throw one last thing in here. We haven't even started talking about cost.
Oh, yeah. Oh, right. So this is cheap, right?
Yeah. Andexanet alpha, super cheap. $30,000 to $50,000 per treatment, as opposed to 4-factor PCC, which is $5,000 to $6,000 per treatment, which isn't cheap either, but compared to 30 to 50,000 is definitely cheaper.
It's a big difference in cost. $50,000. And this is why, I don't know how your hospital works, but every person that I've talked to in different hospitals tells me that there are so many restrictions to using Andexanet alpha. It has to be approved by like a neurointensivist or a neurosurgeon. It's not something that we can just willy-nilly give, which is a good thing. Those restrictions should be there. It actually also makes the dosing easier, because I got to call pharmacy. Pharmacy has to get it approved by one of those people. They help me with the dosing. All of that stuff is really useful to limit prescription. But I would say, based on this data, that we should be prescribing exactly 0, which would be great for me, because it would reduce the number of phone calls I need to make.
I couldn't agree more. I mean, this isn't something that we have readily available at my shops where I work at. I mean, I'm out in a community setting, and so we have 4-factor PCC, and that's basically it. We don't have Andexanet alpha as an option. So I don't have to worry about spending $30,000 to $50,000 of the hospital's money to double the amount of harm that I'm going to cause to patients.
Yeah, so people should go and check out all of the strengths and limitations, our discussion on the website. But Salim, before we wrap up, I do have one more little rant that I need to get into, if you'll allow.
Please.
All right. So this was published in the New England Journal of Medicine. That is a major publication, probably the highest impact factor of any medical journal. Everyone's reading it. I'm not an internist. I still read the New England Journal of Medicine, and I think a lot of people across specialty look at the New England Journal of Medicine, and there was a long time where we could trust the publications in the New England Journal of Medicine. We could say it's in the New England Journal of Medicine. The methodology has got to be sound. This has got to be good information. It should be usable by me without doing this full deep dive. We are not there anymore. We are not anywhere near there. The fact that it has the New England Journal of Medicine seal of approval, to me, actually makes me more skeptical. Because when I see over the last decade is that the studies that are being published are poorer and poorer methodology. They're less and less relevant to patient-centered outcomes. But what they clearly are is more about pushing some agenda of big pharma. And it always brings up the question of why. Why does the New England Journal of Medicine care to push the agenda of big pharma? It's not like big pharma can be like, here's $10 million. Can you put this in your journal? They can't do that. What they do instead is they buy thousands and thousands and thousands of reprints of the article, which they then use to pepper clinicians and say, hey, it's in the New England Journal of Medicine. You have to prescribe this. And they use it to pepper the guideline writers to tell them, you got to put this in your guidelines. So big pharma is using the New England Journal of Medicine for what they want, which is to improve their bottom line, to put more money in the pockets of their investors. That's what big pharma does. And Salim, I can't really be mad at big pharma for doing that. That is why they are here. That is their job. Their job is to make money for their investors. The New England Journal of Medicine, though, their job should be to improve patient outcomes, to make it better, to make clinician care better. That's not what a publication like this study does. This study is simply in the New England Journal of Medicine to get the New England Journal of Medicine more money. And I think that that is an absolute travesty. We should not be thinking that because it's in the New England Journal of Medicine, that it is a good study. And until the New England Journal of Medicine tries to prove that they actually care about patient outcomes, that they don't just care about lining their pockets, we shouldn't be paying attention to a lot of the publications that come out in the New England Journal of Medicine. Salim, that's my spiel. That's my rant. That's my 2 minutes saying that the New England Journal of Medicine ain't what it used to be. It's not your mama's New England Journal of Medicine, and that really makes me sad.
Yeah, it's funny. When we started doing this 10 years ago, we went into this to learn how to decipher a paper, how to break it down, how to apply it to our patients. And over the years, that has somehow shifted a little bit where we're still doing that, but now we're also having to fact check journals and not just go with the headline. Right? Or not just trust the abstract. We're having to dive deeper. We're having to look at multiple different sources, right? To see if they change their outcomes or who's funding it. I mean, these weren't things that we had to do when we started doing this 10 years ago. And your rant is basically saying that it's all about the bottom line and the bottom dollar, and which it shouldn't be. It should be about patients. And unfortunately, that's not the world we live in now. And that is what Rebel EM has turned into. We now are starting to do fact checking too, in addition to methodology checking. So anyways,
I don't want to put in too much of a support for what we do, but for the listeners out there, you will never find Salim or I taking money from any of these institutions. You'll never find us taking money from big pharma. We don't believe in it. What we believe is that you deserve the best information. And honestly, it should not be up to each individual clinician to do this work, to do the work that we have done, to get my blood pressure as high as it is right now over my anger against the New England Journal of Medicine. That is not what you should be doing. You should be benefiting off of my stress, off of Salim's stress. And I hope that you are. And I hope you know that we will continue to hold these journals to the high ethical principles that all of us as clinicians promised to bring to our patients.
Couldn't have said it better. And there you have it, Rebel EM listeners. Let us know your thoughts, comments, and questions. And until next time.